And we're live.
All right.
Good evening, good morning, good afternoon, wherever you guys are. My name's Ashley. I'm sure many of you probably have never seen me before. I first met Forrest and the Kineon guys through YouTube. We started working together. So I could go into a bit of a background. I'm an osteopath of about 13 years. The rest of it, if you want to know, we can, but I would rather just get cracking. And Forrest, do you want to introduce yourself?
Yeah, absolutely. I'm Forrest Smith, co-founder and CEO of Kineon, and we make laser therapy devices. And our mission as a company is to increase the quality of life for the largest number of people we can in the most measurable way we can. And super excited to have Ashley on today to go through. I think one of the things, just to provide a little bit of context for this. I feel are world-class at building laser therapy devices. We spend a ton of time, tens of thousands of hours in the background in the medical literature and understanding the lasers and the dosing in the tissue. But one of the things that's super exciting about having Ashley here today is Ashley does this on a daily basis. He sees people's journeys from pain to possible, and really kind of enables that. And we're here to really support with building the right technology to be able to empower him to do that in a faster and more effective way. But there's nothing like that experience and that real kind of firsthand interaction with people that you've got. And so super excited to hear more about that today. And thank you for joining us.
No, it's a pleasure to be here, and thank you for having me on. So if you are watching this live, please stick any questions related to your back pain in the chat. I can't guarantee we will be able to answer them all, but I will be scanning through the chat. And if there's anything that sticks out, I'll try and answer it if possible. So in today's presentation, we're going to kind of go from the beginning to the end. And it's very important, in my opinion, to help people from all of those stages, because when you injure yourself, there's obviously that acute stage of pain where you can't move, where everything's spasmed up. Then you get to the point where you kind of feel like it's better, but actually the problem's still not fixed. So we're going to talk about what the next steps are, how to keep yourself sort of pain-free for the rest of your life and keep that pain away. So when you injure yourself, let's say there's multiple different ways you can injure yourself, but regardless of how it happens, usually the pain will come on, and it will come on fast, and it will stop you in your tracks. You will go into a lot of spasm, and you'll find that you end up building up a lot of inflammation. The pain usually is kind of a 7, 8, 9, or in some cases even a 10 out of 10. So we need to discuss a little bit about what's going on at that point. So we are in a phase of inflammation. Inflammation is, like, everyone knows the term inflammation, but what exactly is inflammation? Well, inflammation is actually a good thing. I know we all take these painkillers to try and reduce the inflammation, but actually we need inflammation. Inflammation is like signaling for your body. It produces chemicals and molecules that help your body to divert the attention to the area to help fix it. So to do that, the body increases the blood supply, it increases the heat, and all of this is stimulating your body to try and fix a problem. Now, this is acute inflammation, and that's a good thing. What should happen, though, is that inflammation should naturally die down. And that could take 24, 48 hours, even a few days at most. Then you start going into more of a subacute phase where the high levels of inflammation is starting to wear off and your body is starting to repair. Once that has gone, then we end up being in more of a chronic phase. Now, if there's chronic inflammation, that is not a good thing. And something along that process, something along the lines has not worked as well as it should have done, which has led us into this point where we are still inflamed. And that could be weeks, months, or in some cases, maybe years. So we're going to discuss a little bit about what to do for all of that. But the most important thing is that we know what phase we're in and how to get that inflammation down.
Absolutely. And just with one interesting thing, and this is probably giving my age away a little bit, but with inflammation, when we were growing up, when I was younger, and again, I say this with acknowledgement that I've got a lot of gray hairs, and this isn't everyone's truth, but I think we've heard when I was growing up that, rest, ice, compression, elevation is the way to deal with the unhealthy inflammation. And I think we've seen some steering into other directions over the recent years. And likely we can kind of touch on those a little bit later as we get into how to deal with this and kind of, again, that empowerment for people to get away from the I don't think it was necessarily a miseducation. It was the best information that was there at the time, but there's just been more information since then. And this is kind of how science works: is that it's an ongoing bulldozer, and we've got some really powerful tools that's empowering us with these days. So just to jump in there again, hopefully that's not telling my age too much, but we will address a bit of that a little bit further in as well.
Yeah, for sure. And the science is perhaps more up to date, but the professions are not. Like the medical profession tends to be a bit slower to uptake because they want to see multiple studies done for multiple years. So things are lagging behind a little bit compared to what the evidence is suggesting.
100%. I think it's one of the things where you see inertia as a human in so many spaces, but with the medical, when we do some of our medical professional engagements from an educational standpoint, one of the things that we've noticed is that a lot of the medical professionals have been practicing for 30 years. So when they learned this, they were in school 30 years ago, and they were using a 20-year-old textbook then. So the information that they were exposed to may be, again, that just that inertia coming along. And you can't, it's almost impossible as a medical professional to stay up on everything. And so, it's really kind of incumbent on us as, as patients and pain sufferers to kind of go know a little bit about this ourselves.
For sure. I graduated in 2010, so what's that, nearly 14 years ago? And we were taught that kind of stuff back then. And unless you are specifically looking for new approaches, like we have to do a certain amount of CPD per year. And unless you're looking for a specific thing, you might not always come across the latest research. So even a lot of practitioners are still behind the times as well. And so I see a lot of people in chronic pain, not just back pain, but everywhere. And most people are following the same progressions, right? So the way we see it, or the way I see it in clinic, is that people are still using a lot of pain medications, whether that is NSAIDs, so non-steroidal anti-inflammatories, or painkillers like paracetamol, for example. If they don't work, then quite often the next step for a lot of people, not so much the people that come to see me because the thinking is different, but people who are not being seen by practitioners, maybe just going through their GP, they might end up going down the more doctor route. So then the next step might be stronger medications, so stronger painkillers, or they might end up going for, say, injections, steroidal injections, or in some cases we're now seeing things like PRP, but I think they're not so widespread. I haven't met anyone so far that's had PRP, or if I have, then not so many. And then the next step is, if these things don't work, if the injections are not working, then it might be that they go into different medication. In some cases, it might be things like antidepressants, or it might be more of a surgical route. But actually, those that are coming in sort of to see a practitioner, physiotherapist, chiropractor, osteo like me, the outcome might be slightly different because they're getting treatment, maybe they're getting rehab. So actually, sometimes they can avoid surgery. Obviously, it depends on what it is. So
that makes sense.
You were saying about the NSAIDs, the old model. NSAIDs are good. They have a place, and it depends what you have access to. So, like for you guys, Forrest, for example, like you've got access to the red light, and it's becoming more and more accessible. But a lot of people at the moment don't have access to red light. So a lot of people are still following this old model of the NSAIDs, the ice, that kind of stuff. And even with me in my practice, I still recommend to some degree NSAIDs because they have a use, although there are better alternatives. But the downside to NSAIDs or non-steroidal anti-inflammatories, naproxen, ibuprofen, is that first of all, you need to be able to tolerate it. So a lot of my patients maybe can't tolerate it because they already have pre-existing conditions, or they can become addictive, or you can end up with sort of more digestive problems down the line, like stomach ulcers, constipation. So there's only a certain amount of time that you can be taking NSAIDs or any medications to some extent. So what I find myself doing, and I might be jumping ahead, is that when someone comes in with really acute pain, so we're not talking all pain, we're just talking a 7 or more out of 10, I do advise NSAIDs for a couple of days maximum, on the basis that they haven't necessarily got access to other things. So I tell them it's better to hit that inflammation hard with what works, with the NSAIDs, rather than taking a minimal dose, which may reduce it a little bit, but you're still fighting with so much. So I am in the process of editing a video at the moment, and in that I said, imagine you're trying to fight a fire. Let's just say a small garden fire. You have a bucket of water available to you. Would you go and get a glass, dip it in the bucket and pour a glass of water on at a time to try and put this fire out? Or would you grab the bucket and just chuck the whole lot on the fire, assuming it's like a fire that's just getting out of control? So the answer probably is that you're going to just extinguish it with a bucket of water. Now, both methods might work, but if you're doing it with a glass of water, it might be that actually you can't put it out because it's going so slow, putting the water over. So for people who are in a lot of acute pain, I do say, okay, maybe you can use NSAIDs for a couple of days, if, of course, you can tolerate them. So I think there is a place, but generally, if we can try and avoid NSAIDs, then that's probably a good thing.
No, it makes perfect sense. We've done some comparisons for this with the NSAIDs versus photobiomodulation and light therapy. And again, it's part of this is things like we're doing today, where kind of comparisons between those outcomes just haven't been shown to people. And so, to your point with NSAIDs, the kind of acute use, daily use for a couple of days isn't going to hurt anyone substantially. Where you see the massive differences is in cardiovascular endothelial tissue stiffening. But I think part of this is really, to your point, education on both sides of the fence. So what are the new tools? And then, if you're able to use these effectively, and not have to take them chronically, then they're not going to have these kind of stomach-based impacts, the liver-based impacts, or the cardiovascular impacts. Because but I think the one thing that's been shocking to me, though, is that the chronic use. So because these are kind of gold standard best practices right now for many GPs, this is a sense the patient has that this is completely healthy. My doctor gave it to me, and I can just continue taking these for years on end. And we see that with a lot of our osteoarthritis sufferers that are older. And the truth of the matter is that there's something like a 40 to 50% increase in severe cardiovascular disease if you're taking NSAIDs chronically. And it's I don't think that's broadly known. I think that's very well known in the medical side of the, but from a patient side, I don't think that's broadly known, and it gets kind of swept under my GP gave this to me, and it's it's kind of like taking vitamins type approach or sense that people have.
Definitely, and not only about the heart, but also the cartilage in the joints as well. So long-term NSAID use can actually wear down the cartilage. So people who are suffering with arthritic type conditions, long-term NSAID use can actually make their joints or the cartilage in their joints worse as well.
And the fact that that's being prescribed to them for these type of things. And again, with an idea that, like, I think your way of doing it is exactly right. If you're going to use these, use them heavily, use them short term. Kind of that's your fire extinguisher to come put out the fire. Blast it. Let's go, and then get off of it. But the numbers behind the chronic use is just crazy that this is not more broadly known from a patient education standpoint.
Yeah, for sure. So we just touched on the old model, the old Rice model. So the old Rice model was to rest, ice, compress the area, and elevate. Do we go into that in the next? So we will touch on this a little bit in more detail in a minute, but I want to come back to the rest, because that is something I still advise, but I'm going to tell you how I advise that in a bit. And it was interesting, you were talking about the doctors prescribing a medication and patients taking it. Anytime I try and advise on a supplement, you'd be surprised. Well, I'm sure you wouldn't be surprised, but the amount of people that go and do their research heavily into what supplement I've advised them versus being prescribed a medication and just taking it straight away. So anyway, Jack said he did PRP, by the way, on here. He said it didn't help for his back or his neck.
So PRP, and then we can actually make them available here for download. There's some very good recent studies over the past 2 years on people who are non-responsive to PRP. When you're able to do PRP plus laser, they see very strong results because of the synergistic effects. And we can talk about why, but the main thing is it stacks more of the type of tissue. So the platelets and hemoglobin that our infrared wavelengths interact with into the area. And so you can actually dose for longer, you can dose more heavily, and you see really, especially for repetitive stress injuries like patellar tendonitis and Achilles tendonitis, we work with a lot of, so we're working with the U.S. Olympic weightlifting team. And if you can imagine, the snatch, the clean and jerk, it's a lot of pressure, but it's a repetitive motion, and all of them use the same type of things that you're getting these heavy weights overhead. So it's the same elbow, shoulder, lower back, knees, like all day, every day. And so you see these repetitive stress injuries, and they've had very, very good results by being able to add additional platelets into the area to be able to treat more effectively. And it's amazing to see. You can take somebody from a 7 on the visual assessment pain score down to 2 or 3 in less than 2 weeks when they've had that for months and months. It's a very impactful combination between the PRP and laser.
Is it quite easy to get over in the States?
So there's a couple of things that we're synergistic with, and the PRP is the more easy one. We work synergistically with mesenchymal stem cell injections as well. Those are very hard to get in the US. But the PRP is becoming more broadly available. The other thing that we've been doing, and actually that I do myself because I'm in Mexico, in central Mexico now, and I don't have a PRP provider here. And one of the things I do is I use a blood flow restriction cuff below the knee. So I've got an old meniscus tear in my left knee from grappling, and it flares up occasionally, usually from me doing silly things to do at the age of 45, but rugby, getting tackled the wrong way, or box jumps, landing on it funny, or like overloading, ego lifting as an overhead squat or something like this, and it will trigger that. And what I do with it is use a blood flow restriction cuff directly below the knee to occlude, and use the device, the Move Plus device, for 15 minutes while I'm doing that. And it's I kind of think of it as poor man's PRP, because what you're doing is aggregating those same type of platelets and hemoglobin in the area through that occlusion process. And it's that the results aren't as aggressive or aren't as fast, but they are, from what I've seen, and again, it's anecdotally, but from what I've seen in a number of our patients have reported, much more useful than doing it without.
That's interesting. I'd never even heard of that. Over here, I think it's quite hard to get. Like I don't think I've met anyone that's had PRP over here.
Oh, wow. Okay.
So it might be something that's more common over where you are. So the causes of chronic back pain. Now we've got causes in the tissues, and then we've got the causes of like the lifestyle. So what we're talking about now is sort of the lifestyle causes of lower back pain. So the accumulation of wear and tear over years. So we could be looking at, as you get older, you are picking up more niggles. It's slower to repair. I certainly, at the age of 39, feel like it's a lot harder to recover from injury than I did when I was in my 20s, or even just hitting 30. Then we've got like the way we move. Now, most people I see are predominantly desk-based, either people that are working or even retired who may sit around more, or even gardening. Just the activities that a lot of people are doing are don't involve a lot of reach, a lot of squatting, a lot of extending overhead. So we're confined to a very small amount of movement throughout the day. And so over time, it's a case of use it or lose it. If our body's only moving in a certain range, then the body doesn't need the rest. So we start to become tighter over time. Not only that, but a lot of people I see are not exercising, particularly sort of more office-based people. And I'm not saying everyone, but there's a large chunk of people that don't exercise, don't stretch. And of course, with that comes sort of maybe poor nutrition as well. So these are all predisposing factors towards injury in the future. Then we've got like acute injury. If you tweak something, like for example, Forrest, when you're playing rugby, if you tweak your knee or you tweak your back, there's that acute phase. Now, if that doesn't get sorted, sometimes that can turn into more of a chronic issue. And then, of course, we've got like the lack of education towards how we move, what we have to do. A good example of this is posture. A lot of people in offices still having their occupational health come in and say, this is the posture you need to be sitting. You need to be sitting upright, shoulders back and down, monitor a certain position. And that's what they expect people to sit in all day. Now, I don't agree with this, because it could be the perfect posture, but only for a few minutes, because movement is so much more important. Whatever posture you're in, you're either going to be tightening up or you're going to be overstretching a certain ligament or tendon or muscle. Now, if you're staying in that position, then you're going to obviously become imbalanced. So when it comes to posture, for example, my opinion is that we have to keep moving. It's okay to lean forward. It's okay to slouch back and go onto your side and twist a little bit. I tell people that they can go into any position as long as they keep moving throughout the day. And obviously, if anything causes them pain, then just stop. So that's kind of the lifestyle causes of chronic pain, or back pain in particular. And then we've got the sort of the tissue-based causes. Now, the ones that you guys can see on the screen right now are not the only ones. These are the most common ones I see in practice. I see muscle spasms. That's probably the most. That goes along with tendon inflammation as well. A common one.
And that's typically also a kind of protective effect, that your body's trying to protect the area and spasm in a way that's going to, you've tweaked something on one side and maybe on the other side it's spasming as a balancing or protective factor.
You've got like long-term spasm and like acute spasm. So when you've just tweaked your back, your whole back's going to lock up. You're not going to be able to move. You're going to be walking like a robot, and it'll be incredibly painful. But then as that pain starts to ease up, you're just left with generalized tightness, and you don't really feel like it's in spasm. But most people who I see who have got chronic back pain are tight, and not just in the back, but the areas around the back as well. So anytime a part of your body is in pain, everything around it is going to tighten up as a way of trying to protect it. So you're 100% right. It's all about protection. I see quite a lot of disc issues, disc bulges, disc prolapses, disc degeneration. We can touch on that if anyone has any questions regarding discs. We can certainly touch on that in a bit more detail. And then, of course, ligament damage as well. But ligament damage is possibly a bit less common This you would kind of see in people who have more of a traumatic type of injury. So car accidents, for example, or being hit by or falling off a bike, something that's had a lot of impact, that's caused a lot of stretch to the ligaments, particularly for the lower back. Like ligaments can be quite easy to damage elsewhere, but for the back, it tends to be nerve, muscle, and disc. And in regards to the nerve irritation, that can either be from direct pressure from the disc bulging out, or it could be more of like an inflammatory type issue. So anytime we have inflammation, sometimes you can expect the nerves to be sensitized as well. Disc. So more on. So a couple of people are wanting a bit more on discs. Do you guys want me to explain a little bit more about like what discs are, or are we looking at more type of treatment that you want for discs? Let me know in the comments if you can. When it comes to discs, this is going to be quite helpful for a lot of people, I think. I always think of discs a bit like a jam donut. So you know how you've got like the doughy part of the donut? In the middle, you've got the jam filling, right? Now, I don't have anything here that I could kind of explain, but imagine I've got the donut sitting on my hand, and then I've got my hand on top of it. And if I push down, what would probably happen within that jam donut is the jam would spread out evenly throughout the donut. But if I was to push down like a wedge, then the pressure is going to be more at one side and less on the other side. And this is kind of what happens with the discs. So as I press down here, it's more likely to push the jam out the open side. So when it comes to discs, we are more likely to have a disc bulge or a disc prolapse at the back side of the disc. Usually it will come out more to one side than another. We have different levels of disc prolapse. So we have a disc bulge, which is where nothing has come out of the disc. And then we have a disc prolapse or disc extrusion. And this is where the gel-like substance within the disc has actually leaked out from the disc. Now, discs are a bit like rings of an onion. So they're made up of lots and lots of rings. Over time, these rings can become worn. And then, so it's not always just one thing that causes the disc to prolapse. It's years of wear and tear, years of using your body in the wrong way. And then eventually what happens is those fibers all become so worn that you could just do something really minor, like pick up a phone off the floor, and then that will be the straw that broke the disc. So that's when the substance comes out, and that will usually be accompanied by a lot of inflammation. So hopefully that was a bit of a quick summary of discs. I can go into more a bit later if you guys want.
I just like to provide a little context with the laser therapy piece for it as well, because we get a lot of questions about treating herniated discs, and there are mechanical aspects of that we don't want to overpromise and not deliver what we're saying we can do. And what we have found from both the literature and our user kind of interactions as well is that there is typically inflammation-based pain and inflammation-based limitation for recovery. And that's the piece that we can help with. We're with the actual, with the disc bulge and the mechanical aspect to that, with the laser therapy, there's a limited amount we can actually deliver for that. But being able to reduce the inflammation means that the tissue around is enabled or empowered to heal faster, and that you can actually, with a number of different treatment modalities, likely gain a lot of the function that you would have lost and get out of the pain that you would have been in this space. Do you have any suggestions if people, and I know there's many different grades of kind of severity for the traumatic impact on the tissue, but say someone's on the kind of lighter end of that scale with a herniated disc, and we're able to help them with reducing the pain and doing some level of movements. Are there movements around this that can help them to improve their long-term outcomes from those herniated discs?
Yeah. So anyone who has a disc issue, whether it's a bulge or prolapse, the worst movement you can do is bending forwards. Well, any kind of flexion exercise, it's actually worse to bend forward and twist. So if you were on a chair, for example, bending forwards and twisting to try and get something out of your bag, that's probably the worst position you can be. So when it comes to exercises or rehab or dealing with it, avoidance of flexion-based movements is a good start. I quite often recommend hanging. So if you've got a bar above you, grab hold of the bar, keeping your feet on the floor, because most people will have fairly weak grips and won't be able to hang for long. So keeping feet on the floor, grab the bar above you, and then bend your knees. As you bend your knees, you will allow your pelvis to kind of drop down. Now, what this is doing is the weight of the pelvis and the legs are coming down. And because you're holding on above you, that's putting like a pulling force, a traction force through the vertebra. I've actually got spine here. So I probably should have pulled this out a minute ago. But you've got the vertebra and then discs in between. So as you're hanging, the vertebra above and below will start to spread apart. So what this does is it creates kind of a negative pressure and allows that gel-like substance or the nucleus of the disc to kind of be pulled back in. It doesn't always work and it's not a guaranteed thing. But I say to a lot of my patients, the more you can consistently do it, probably the greater chances of it coming back in. And also depends on the grade of the disc bulge or disc prolapse. So if it's just a bulge, you're more likely to have a good result. Whereas if it's like fully prolapsed out, extruded out, then you're probably not going to get so much of it back in. And there's obviously a limit. So this might resonate with some of you. I tried to explain it to someone earlier today and he had no clue what I was talking about. But have you ever had a toothpaste tube and you squeezed out too much toothpaste? And then you're like, oh, damn. So then you start trying to squeeze the toothpaste tube to try and suck it back in. That's kind of what I think of the discs as. Obviously, it doesn't help if you've never experienced that. But that's probably one of the most beneficial things. Then it's just a case of allowing the inflammation to go down and then starting to reintroduce the flexibility and strength around the area in a more progressive sort of rehab program. But hanging is a good one for most people.
Excellent. That's really good advice. And I think, again, paired with something kind of like these laser treatments to improve the quality of the soft tissue around the joints. It'd be great to see people starting to test this and kind of get back to us with feedback as to what they're seeing from that. Because, part of it is, getting the inflammation down and allowing your body's natural healing processes to go to work can be a very powerful tool for it. It looked like we also had a couple of questions in here about scoliosis. Is that something where we could, because it does sound close enough.
We can go on to that, but I've just seen one come in. We can touch on scoliosis, but I saw, was it Kurt? Maybe someone put in a question about inversion tables just now. I don't know where it's gone. Oh yeah, I've seen it. Do you recommend inversion tables, and how does that compare to hanging? So both are really good. I think hanging is probably harder to do physically because you're relying on your grip strength. The good thing with hanging though is that it's free, and you can probably do it almost anywhere. Inversion tables I haven't actually used one myself, but I have recommended them. They do take up a bit of space. So over here, particularly in London, where our houses are not particularly that big, space is an issue. So if you haven't got the space, it can be a difficult thing to have in your house. But they're easier to use for a longer period of time. So once you've got used to the initial kind of feeling of being tipped upside down, then there's probably a better long-term solution. So yeah, if you've got access to an inversion table or you have the money and the space, then definitely I would recommend them. Scoliosis. Yeah, so I guess it's relevant because scoliosis affects the spine all the way up. let me just explain a bit about what scoliosis is. So generally speaking, we have two types of scoliosis. We have a functional scoliosis and a structural scoliosis. So a scoliosis is when, so hopefully that's fairly straight. So the idea is that when you look at a spine from the back, it should be fairly straight, it should be vertical. Now, scoliosis is when the spine starts to bend sideways. It can either be bent sideways like a C, so that's called a C-shaped scoliosis, or like an S, which obviously I can't do with one hand. A structural scoliosis is when the spine has changed because of the structure of the vertebra. So you can't really change that. And most of the time when someone comes in to see me with a scoliosis, they tend to be fairly minor. I have seen a few where it's quite major, and that will usually, depending on how severe it is, may require surgery. A functional scoliosis is when, let's say I've tweaked my back and the muscles on one side of my spine have all gone into spasm, or my pelvis has maybe gone into a bit of rotation. That will put my spine out and make it go into a bit of scoliosis. We can test which one it is by getting someone to sit and then lean forward. Now, when you are standing, for example, it could be a leg length discrepancy. So it may not even be spinal related, but because one leg may be longer than the other, it might put the spine out. But if you sit them down, then that will balance out the pelvis. Then when they sit down, if the spine then sort of straightens up again, then it's probably more functional. But if when they're sitting down and bending forward, it's still misshapen, then it's more structural. You can do exercises to try and correct. This sort of stuff will take years, probably, especially if it's structural. If it's functional, then I could have a scoliosis right now, and then I could wake up tomorrow and it could be gone. So depending on how bad the spasm is or how chronically tight certain areas are, it may be very transient. It may just come and go. But generally speaking, flexibility for the side that's short, and then flexibility for the side that's short, and then strength for the side that's curved to try and counterbalance that. But scoliosis can be a pretty tricky thing to deal with, particularly if it's more structural.
Oh, that makes sense. And I appreciate you going into such depth on that, because it sounds like a particularly painful and uncomfortable pathology to present.
It will be if it's quite severe. Yeah. If it's minor, like you and I probably have some element of scoliosis, but we don't feel it. But when it gets to a certain point, then you start getting rib compression and organ compression and stuff like that. So it can be pretty uncomfortable.
That's awesome. Really, really awesome answer there.
So let's move on before we go down rabbit holes. Now, we were talking earlier about the old model, the rest, ice, compression, elevation. But this model that we have here, the peace and love, is a newer approach, and it's probably one that you're more familiar with, or this is probably your an acronym, I would imagine. Did you guys come up with this?
One of the things I'd really kind of noticed about these, because there's another one called Meet as well that we've seen. So, but this is a very good one. Peace and love really takes into account kind of the mental aspect, because there is a mental and neurological aspect to pain, and regardless of where the pain is in your body, we try to tailor all of our activities as a organization around our mission. And our mission is to increase the quality of life in the most measurable way we can. And it's a very frustrating thing to find for pain that there's no direct objective measurements for this. Much of it has a situational, environmental, and a stress level built into it as well. So if you are at a higher stress level, but you have the same kind of tissue damage, you can be at 2 to 3 times the level of pain sensitivity for that. So I think one of the very interesting things about the newer models that we've seen versus the kind of the rest ice compression elevation is Where in the older days, it took kind of into the physiological aspects. These neurological and kind of mental aspects are more considered these days. So if you look at both of these, the peace and love, education and optimism, it doesn't really sound like we're measuring something out of someone's physiology, but those two are two of the biggest pieces to kind of consider relative to particularly chronic pain. Chronic pain is a really heavy impact from a psychological and long-term kind of quality of life standpoint. It's things where we see people, particularly with our older patients who have chronic pain. It's one of the reasons why we spend so much time trying to get them into something that even with incremental ongoing improvements, it's really worth it for them, because what you'll see as with chronic pain and particularly around joints and lower back is that if you can't get out of this, someone ends up in kind of a downward spiral that can increase their all-cause mortality drastically. And for us, again, that's one of the reasons why we've committed to our mission of improving this quality of life so much in the long term. But yeah, that was one of my takeaways from this the new ways of kind of new modalities for treating are more inclusive of that and are more successful because of it. But the elevation actually is kept. We've kept that since the rice. The compression we've kept, but the avoidance that we've put in there now is long-term chronic use of anti-inflammatories and ice. And there's a couple of things that happen with ice, but one of the things that we've found, and we have, again, we've done the comparisons on the kind of medical literature on the outcomes relative to the tissue is, we were talking earlier about the difference between acute and chronic inflammation. When you're using ice, you can reduce inflammation, but oftentimes you're reducing the healthier inflammation relative to triggering that regrowth of the tissue around the wound or the tissue damage. And so protecting this, elevating, avoiding kind of things that are going to make it worse or allow you to not heal, like the chronic anti-inflammatories and ice, and then compression and education. How do we manage our minds and our neurological kind of even down to optimism. Optimism has a huge impact. How am I going to look at my journey from pain back into possible? And if I've got a positive outlook on that, I physically heal faster, and I get through this process of getting back into regular movement much more quickly. So there's a number of tools we can kind of make available offline for this. But really one of the takeaways that I would say was most impactful for me personally is maintaining a positive outlook, optimism, and being as educated as possible on what those impacts of the disconnect between necessarily physical damage and pain. You can have pain without physical damage and physical damage without pain. And so there's recognizing what you actually have from a kind of diagnostic standpoint and being able to manage that relative to your outset, relative to your mindset and your perspective and your optimism is really important.
For sure. There's a couple of things you said there. So hopefully I can remember all of them. One was about the presence of damage, I think it was. I see a lot of MRIs. What you see doesn't always correlate with what pain someone is in. Now, you and I right now could be sitting here with disc bulges, disc prolapses, we might not even know. But we're in no pain. Whereas someone could have excruciating back pain and yet not have a disc problem. Or they could get an MRI and see a massive disc bulge, but then could have no problem. They could have no pain. So what you see doesn't always correlate with the pain. So that's just something for because people often ask, should I go and get a scan? Should I get an X-ray, MRI? And most of the time I say no, unless clinically there's a reason for us to think that could be something. So if I think there is a disc, then I would get an MRI because I want to confirm, not because it's going to change my treatment, because if I'm already suspecting a disc, I won't maybe manipulate the spine. So that's one thing to be aware of. And also when it comes to the education and optimism, I think that's massive as well, because when you don't know what's going on, it makes things worse. And sometimes then that leads to people searching online and finding out answers that actually may not be relevant. So if someone knows what is going on, then they're more likely to know what the prognosis is. Even if you know what's going on, one of the more common things that I hear people saying is, will it ever get better? And as soon as someone knows that it will get better, even if it could be a time frame of a year, they're still more optimistic than if they don't think it will ever get better. So from that point of view, a good diagnosis is very important, and also just doing as much as you can to try and fix the problem like yourself. Don't just rely on a medication. It's down to us as patients and practitioners, of course, to work together and get people moving, get people stretching, strengthening, doing red light, doing massage gun therapy, foam rolling, these kind of tools that we have available to us. The more of these we can do, the better the outcome is likely to be.
100%. I love it. I think that kind of takes us back into the last piece of the love there, which is exercise. And I think with your experience, one of the things I've had back problems in the past, and one of the things that I've noticed is when I leave it alone and I don't do anything with that back pain, and typically mine is mostly self-inflicted, me just being a knucklehead and lifting too much. Being a tall CrossFitter is a painful thing to do. But if you have your my lower back go out, the old way of treating that was just stay off of it. Don't do as much. What I found now, and we've been working with our scientific advisory board to kind of put together protocols around, and I think you'll have amazing input on this, is what's a safe way for me to start testing the waters with getting back into movement if I do have this kind of back pain, so that I can actually start getting more blood flow into the area in conjunction with, like you said, massage gun, laser therapy. There's a number of different modalities that could help with that vascularization and increase blood flow in the area. But what kind of movements would you recommend that people start with to stay safe but still bring movement back into their routines?
Yeah, definitely. We're going to actually touch on a few of these exercises in a slide or two's time. This slide here is just saying, like, what can we do about the pain? Now, we can either build our resistance. So we've got two cups here. We can either decrease the amount of water. So if you've got a cup, this cup can only hold so much water. If I overfill it, it's going to spill out. So the cup represents your body and your tolerance to pain and your ability to ward off injury. Now, as we neglect our bodies, we're going to be filling the cup up with more and more insults to the body. At some point, the body won't be able to tolerate it anymore. So then you'll start seeing disease or injury. Now, there's two ways that we can either combat this. We can either reduce the amount of water in the cup, so avoidance of things that are likely to be making us become in pain, or we can build our tolerance, so we can build a bigger cup. And it's important, I think, to do both. So making sure we've got good education around the way we move, the way we sleep, the amount of sleep, good nutrition, good practices with everything just around your health in general. And then building more resilience is things like, have you got a good mobility plan? Have you optimized your sleep? Are you strengthening your body? So if we can balance the two of these, then I think that's going to help us immensely as we go on. So these three tips we've got here, these can be related to both acute and chronic. The reason I paused is because I was trying to figure out which one I was going to talk about, but I'll just do both. So a lot of the time when people have back pain, sitting often makes it worse. Now, earlier we talked about the rest, ice, all that kind of stuff. Rest is good and bad. So anytime you have acute pain, if you keep trying to move, you're going to make your pain worse. It's going to weigh you down mentally. So I tell people they have to rest. But then the next sentence I say is, but you also have to keep moving. You need to rest just long enough for the pain to ease up, just long enough for you to get recovery and to allow your body just to calm down a bit. But then you have to move, because if you're staying still for too long, things start to stiffen up. So then when you start moving, it's going to feel more painful than it did before. So when it comes to sitting, it's okay to sit, but try and keep moving, try and keep changing positions. Things like long car journeys are a nightmare. There's an exercise I've got coming up, the cat and cow. If you can do that in the position I've shown, then you can do it any position. So you could do it standing, you could do it lying down, you can do it in a chair. So even when you're in a chair, you can still do your cat and cow just to keep the spine moving, keep the muscles working. Now, particularly when someone comes in with acute back pain and they try and stand up from a chair, they get kind of to this halfway point, and that's when the pain kicks in. So I have a little way of doing it. It's going to be quite hard to show here because I won't fit in the screen. But I tell people to shuffle towards the edge of your chair. So you've just got your bum just on the edge of the chair. You bring your feet just underneath you slightly. So we can all try it. So you bring your bum to the edge of the chair, feet underneath you, hands point inwards and place them on your knees. So then you rock forwards and lift your hips at the same time. So you're not actually using your back, you're using your legs to stand. Then you walk your hands up your legs to stand up.
Nice.
If that doesn't make sense, I will try and demonstrate it, but hopefully that makes sense. You use your hands on your knees to stand up and then use your hands to walk up. Now,
and I guess when the reverse back to sitting down, if you have back pain maybe as well, just to kind of take the pressure off and keep it onto you're kind of almost using your arms as braces to get you into the right position.
Yeah, don't just plonk yourself down in your chair, particularly if you have a disc problem. Then sleeping. Now, I've had back pain. You've had back pain as well, right? Yes. I did. For those of you who don't know, I injured my back squatting. I was at the bottom of a rep, and as I came up, I felt a pop. And then I had pain for years, but mainly because I didn't do all the right things to fix it until I finally decided to actually follow the right advice, and I started building myself up. Anyway, sleeping was one of the worst things to do because it's hard to stay sleeping in one position. So whenever you have to move, you have to activate your back, and that can cause pain. And then when you wake up in the morning, it hurts because you're so stiff because you haven't been moving. So sleeping is tricky for a lot of people. I really like knee pillows. So if you can just get them on Amazon, they fit between your knees a bit more comfortably than just a standard pillow. I actually still sleep with one now, even though I don't have back pain, just because it just feels comfortable. So if you have back pain, then it's worth sleeping with a pillow between your knees. Also, try and keep moving if you can. I recommend a lot of my patients take magnesium. I don't think we've covered supplements in this presentation, but magnesium glycinate is incredible. Well, for everything, but for back pain or for pain, because one of the major things it does is it helps to relax muscle. It also helps to reduce inflammation. And magnesium glycinate helps with sleep. So I get a lot of my patients taking about 400 to 600 milligrams of magnesium glycinate in the evening. They can spread that out, say 2 at 6 o'clock, 2 at 8, 2 at 10, or like in my case, I just take it all at once because I forget to take it spread out. But that magnesium gets absorbed into the body, helps your body relax, and might help you get a better night's sleep. But if you can't sleep, you can't sleep. You know, sometimes you just have to get up. We touched on this one. So presence of damage doesn't always equal pain. I think we'll just skip that one, shall we? So
this is the lovely cat cows. Yes, we had a question from Linda, maybe, who was wondering about cat cows.
Sleeping position is important. No more fetus. Yeah. So basically, Linda's just said everything I just said, I think. Pilates roll down, roll ups. One thing I haven't really mentioned in this is that I kind of work in 3 phases. And I think you guys have mentioned this before as well. Phase 1 is usually when someone comes in and they're in extreme pain. So there's going to be a lot of inflammation. Phase 1 is purely just about doing the right things to get the pain and inflammation down. Once the pain comes down to about a 6 or a 5, we can start moving into phase 2, which is about restoring the flexibility and mobility. That's what we're going to touch on now. Phase 3, once the pain comes down to about a 2 or 3 out of 10, that's when we start trying to rebuild the tissues, rebuild the strength. If you miss a section, so let's say if I had back pain and I went from phase 1 to phase 3, it actually makes me more likely to get pain again, because if I'm tightening up already tight muscles through strengthening, then I'm predisposing myself to injury. So you have to get that balance. Now, sometimes people are already naturally quite flexible, in which case they don't need to do the stretches. So for some people, they can miss phase 2, the stretches, but for most people like me, I would need to do a phase of stretching. So cat and cow is a great exercise. It's great because it's low impact, it's low load on the spine, and you can do as small a movement as you like or as big a movement as you like. The reason it's good is you start getting flexion, extension through the spine, so it's starting to loosen the spine up in that direction. But then you can also start to add in rotations. So I think they call it the thread the needle. And then I get my patients to do like side bends as well. So you can get 3 different movements from this one position. When you do this, I say to my patients, just start with millimeters of movement. Just keep going up and down with tiny, tiny movements. As you start to ease up into that range, then you can go a bit further. As you start loosening up, you push it further and further, but you never push it into pain. If you push it into pain, you're stimulating your pain receptors. That then causes your muscles to spasm. So you want to try and avoid that. So cat and cow is a really good one. About 10 reps. It doesn't matter whether you call a rep 1 up and down or whether just down is 1. And it's a loose thing. It's just a movement. We're just trying to get movement through the spine. But 10 to 20 reps is a decent range. Have a rest and then later on do another set. This one is one of the most needed stretches for most people. As I said earlier, when we've got back pain, the muscles around go into spasm as well. So the muscles in your hips will also get quite tight. Most people are very tight in their glute minimus and medius. So they're the muscles at the side of your hips. Almost every time I've treated a patient with back pain, they've always had spasm or tightness in those glute minimus medius muscles. So this stretch is a really good way to do it. You just sit down, put one foot on top of the other knee, hold on to the shin to stop your foot from falling off, and then push your knee down. I tell a lot of my patients that they can do this while reading an email. So those people who work at desks, just use this as part of your routine throughout the day. If you can get your leg horizontal, that's ideal. If your leg is like up here, then you need to be able to keep stretching until it comes down. If you find that that's too easy, then there's a variation that you can do on the floor as well. But essentially, stretching the glute minimus medius is very important. And then, as we've already mentioned, hanging. So this is just more of a visual of what I said earlier. Hang onto a bar, feet stay on the floor, bend the knees, allow your abdominals and back muscles to relax, and allow that to pull down on your spine. I tell my patients to do a minute, but that's a minute combined. That's a minute total. So if you can only hang for 10 seconds, then have a rest, come back, do another 10 seconds, and just keep doing it until you've done a total of about a minute. And you can do that multiple times throughout the day. Once your flexibility has improved and your pain is about 2 or 3 out of 10, then it's time to start strengthening. We have to start with the most basic of exercises just to make sure that we're not going to flare the pain up. So in this case, we've got hip bridges. These can be good and these can be bad. The key with these is to not use your back. So if any of you are going to do hip bridges, when you're lying down on the floor, push the small of your back into the floor. So what this will naturally do is start to roll your pelvis backwards. And then you keep rolling that pelvis backwards while pushing your heels into the floor. And it's that thought of pushing the floor away that continues that movement and allows your hips to rise. If you're thinking about your heels and not thinking about how high you can go, then you're probably not going to go into overextension of your back. But it's when people start to think about trying to lift their hips as high as they can, they start overextending their back, and that can be quite a painful position and can be quite aggravating for some people. So if you're going to try this, just be very aware of how you're doing it. So push your heels into the floor and keep your abs tight and lift your hips using your glutes.
One of the things I noticed about this type of hip bridges exercise as well was that having had it after a back injury myself, it was very surprising to see how little my glutes were firing. And I think part of that's just in modern day we sit too much. We're kind of, and even now as we're talking about specifically this, and I'm still kind of leaning forward. I'm interested and engaged for this content, but it's putting strain on the lower back, and but it also kind of turns off you shorten these kind of psoas and hip side muscles, and then somehow the glutes just turn off, and so that was one of the things that I had to think through was continually think about the glutes firing during that process versus kind of loaded. That when the back is loaded, it would do exactly what you're saying. If I just kind of just did it like in a mechanical way, the back would carry a lot of that weight, and it would kind of flare up again, and you'd feel these kind of spasms. But if you can make sure that those glutes are firing, because you don't think about your muscles, or at least I didn't, and maybe I'm uncommon in that, but I never thought about my muscles turning off or being disengaged when they should be engaged. But because of how we're using them now, again, from a sitting too long and staying in static positions with them kind of completely stretched out, it turns the muscle off and it just won't fire effectively.
Yeah. And also it is a reason why people end up with pain as well. For example, when we're doing squats, it's usually the back that goes, and that tends to be the weak link. And it's because either we're using other areas of the body too much, or those areas are not strong enough, so we're putting too much load into the back. And quite often when we're doing things like resistance training, we build up so quickly the strength in the muscles, but we forget to realize that the tendons take a lot longer to strengthen as well. So being aware of feeling your muscles as you're doing any exercise is incredibly important. And when we're doing squats, like particularly ego lifting, we're just trying to get that weight up, and so we're not really focusing on engaging quads, engaging glutes, and it's just a case of whatever works and get it up. So this one is strengthening the glute minimus medius that we went through just a minute ago. So this one is more hamstrings and glute maximus. This one is more glute minimus medius, so this is more to the outside. So you're just standing on a hip, dropping your hips down, and then trying to hitch your hip up. The alternative, there are a couple of alternatives to this. If someone has, let's say, a really bad tolerance to movement through the spine, so maybe there's a real bad disc issue or compression of some sort, that dropping down of the hips may irritate some people, in which case they would not do that one and move on to something else, like a banded sidewalk, or if they've got access to the machines, then like hip abduction machines. So there's always an alternative to exercises. Whatever program you've got, if it doesn't feel right, there's always an alternative. So don't feel like you always have to stick to that, what you've been prescribed. Now, this is probably the exercise that actually fixed my lower back. So my lower back issue was the tendon. It's where the erector spinae, the muscles that come down the spine, attached to sort of the sacral area. So it's the tendon. I damaged the tendon, and for the exact reason I just said, where the muscles were stronger than the tendon, because I was trying to progress the weight too quickly. So back extensions are incredibly useful. The danger is if you have a disc issue. I have done this multiple times with people with disc problems, so it's not something that they can never do, but we just have to be aware that we're going into flexion. So you would only do this really if you've built up your back before that. In my experience, most people are incredibly weak on this exercise. So when I start a patient on this, usually they can only get about 5 or 6 reps. What we want to do is build up to 3 sets of 10 reps, and that's body weight. And then we can start going into loaded. But this is really good in my opinion, because it is targeting those erector spinae muscles and a bit of the tendon as well. There's multiple ways you can do this. The setup will make a difference to what you're targeting. So in the pictures that you can see, I've actually got the pads quite high. So when you feel your pelvis, you'll find 2 like bumps at the front of your pelvis on either side. So I've placed the pad just underneath that. The reason is because I'm trying to stop movement from my pelvis and from my hips. If I position that pad lower, then it will allow my pelvis to rotate over. So that will start targeting the hamstrings and the glutes more. So neither are wrong, but you've just got to know why you're doing a certain type of setup. So whenever people have seen, let's say, a video online, I put up a video of how to do this online. There's always that one person that says you're not doing it right, you've positioned it wrong, and it's not. What they don't realize is that it's how you set it up and why you're setting it up. So if you're going to do it for your lower back, position the pads a bit higher. Then think about trying to flex from the top of your spine down. So I'm flexing from my shoulders, chest, belly, and then so on. Then when I come up, I'm lifting from my chest first and then higher and higher as I go. The reason is because I'm trying to lengthen and contract those erector spinae muscles. Sometimes you'll see people do it like with a fairly flat back, which is fine, but that's now targeting more hamstrings and glutes. So again, if you know why you're doing it, then it makes sense.
It makes perfect sense. One quick question from the group here was, if we don't have this physical device, could we use a stretching ball to be able to kind of, as long as, and it sounds like as long as they're kind of aligning their pelvis correctly towards this to either indicate for the back or for the glutes and hams, then that's maybe something they could use as well.
Yeah, you can use the full-size balls. Mm-hmm. Position your feet up against the wall so you're not going to roll off the ball. So you can use the full balls, or you can use a Bosu ball, like the half dome balls. They can be quite useful. Or if you don't have any of that, you could just do it flat on the floor. It's a little bit more difficult to get that range. So if you're flat on the floor, you're going from an already neutral position into extension, as opposed to what you can see on these pictures where you're going into flexion. You can get kit, which you can, say, tie to your bed to lock your feet in place. But for most people, just starting with doing it on the floor is absolutely fine.
Awesome. Fantastic. I have to say that we're getting some really positive feedback in from the group here. And I feel like I have to just kind of double down on that. This is amazing. So just to kind of give a small summary after we've gone through those, and I know we've got the phases here, but just for the takeaways for people to remember a little bit, magnesium glycinate, knee pillows, stretch, let's phase this, reduce the pain and inflammation, improve flexibility, and then rebuild strength, kind of like we're looking at the slide here, and then make sure that we do those in that kind of phased process. And then we've got great, at-home versions and that you've described. And if you have a kind of a back extension machine at your gym, you can also use those. But that was really, really practical ways for us to start seeing some improvement in flexibility, strength, and hopefully in reduction of pain over time as people want to go take this forward. Was there anything I missed in the summary that I feel like there was one other thing that I wanted to note in there, but those are all very practical, hands-on. You can do this very soon, if not today, type approach to it. And it also allows you to take, an approach to, most people know their body for, are they in that kind of short-term kind of spasming pain and inflammation phase, or are we in a phase where we can start looking at flexibility and mobility and working tentatively through that? Or have we been through this already and are we back into kind of rebuilding strength and stability? So that's a really, really an amazing way of kind of phasing these type of things. But I feel like I may have missed something in there that was one of the more practical pieces that they could take away from this.
I don't think you missed anything, but what I would say is that it's not always linear. So you don't always just go from phase 1 to phase 2 to phase 3. There will be times when you might flare up. So you might go back to phase 1. So you just base it on how your pain levels are. So if you started to do your strengthening phase and then your back flares up, that's fine. Just go back to phase 1, follow all the advice from that, then give it a few days, go into a bit of stretching, and then start building it back up again. So if you just keep figuring out where you feel like you fit along that spectrum, then you'll be fine. But don't just try and battle your way through thinking you started phase 3, so you just got to keep going.
Excellent point. It's always dynamic.
So I guess this brings us to your stuff.
Yes, we again, we don't, and this is one of the reasons why I get so excited when we're talking about these things, because we're focused on one aspect of this kind of recovery process, and it does help. There's transformative effects for kind of soft tissue, increased kind of vascularity coming to that tissue, beneficial neurological impacts, increased blood flow. One of the biggest things we see short term is a lot of times, particularly around recent injuries, you can see a stagnation, and one of the ways we measure that is with infrared cameras. So you can get infrared cameras now, and with a lot of the athletes that we work with, you can take a picture of where they've torn a muscle, a month ago, and they've been through the rehab, and they're kind of getting back into training, but you still see this cold pool of tissue where the blood delivery to the area is not as effective. The cardiovascular delivery to the area is not as effective, and so they're going to have an increased rate of re-injury to that tissue longer term if they can't fix that. But with the laser therapy, particularly the infrared part of the laser therapy, being able to penetrate so effectively into the internal tissue and reduce the inflammation. The other thing that it does that's I think probably less known is we generate a higher level of serum nitric oxide, so more nitric oxide dumping into your bloodstream. And there's a couple of impacts from that. And I think, it's one of the things where very recently we've seen a kind of a paradigm shift from what's been a 2-gas system for our cardiopulmonary system, which is oxygen and carbon dioxide, to a 3-gas system to include nitric oxide, because it's really one of the big things that steers where blood goes in your body. And it's a very easy way to test how healthy, or in some cases, the medical researchers are now using it for an aging test for cardiovascular endothelial tissue. So your cardiovascular endothelial tissue stiffens as you get older, but it also, one of the ways that you can test this is the nitric oxide that it can hold, the level of nitric oxide that it's able to kind of take in and push back out. And so this is measured oftentimes in very simple tests like occlusion reperfusion tests, where you cut off blood to an area, and then when it's healthy tissue, it reperfuses with oxygen much faster. But that's really driven by the nitric oxide being effectively taken into the endothelial tissue and then pushed back out. So, long story short, that's a lot of biochemical gobbledygook for most people listening. And they are actually asking me to try to make this a little bit more approachable. But the main takeaway from this is that you can really treat in 4 to 5 weeks areas of your body where you've had injuries and that they're not delivering oxygen in blood as effectively by using laser therapy. And we're super excited to see what impacts that has on a lot of our users, because that's what we're here for, is really to impact people's lives and help them get out of pain and inflammation and give them another tool. But I really love taking the broader look that you've given us today, Ashley, on how this fits within, a number of different things that you can do. And it's not the be all and end all as much as we feel it is with our work in the area, but it is a good tool. And we feel like this is something that with education and kind of continued ongoing programs like this, we can get this in front of people and steer them away from, particularly one of the things we'd really love to see is older users in osteoarthritic pain and lower back pain, moving away from NSAIDs and injections and moving towards something that's going to give them maybe not the immediate relief, but the longer term health and recovery that's going to make them enable them to have better movement and healthier movement patterns and get back into a quality of life that they really want to have. And so really appreciate you taking the time to walk us through all of this. It's been such amazing, directly useful pieces that I think the listeners can take away and implement immediately. And it's again, it's so exciting. I'm just, I don't know if you can tell, but energetically, this has just been kind of building me up a ton, because I know that this is going to make an impact on people that take the time to go.
The information's all there, so they just have to follow the plan.
Absolutely. And again, it's I think for you, maybe it's something that's been baked in from an educational standpoint, but taking the time to come do this with us is going to make a huge impact on a large number of people's lives. And we really appreciate you taking the time to come.
Nice. It's absolutely my pleasure.
Thank you.
No, if I can chat about stuff that helps people and chat about what I know, then I'm all for it.
Yeah, you're an amazing wealth of knowledge in this space, and I really hope that our listeners and future listeners will take something away from this, because it's not often that you get an expert in a space that's willing to come in and really kind of expound on things that aren't necessarily just the medical terminology for it, that are giving these people something that they can use today. And that's a really powerful tool that you've put in their hands.
No, it's awesome. And of course, if anyone has any questions, they're more than welcome to reach out to you guys, to me directly. I'm always there to help.
Really appreciate that. Thank you so much for taking the time with us again today. And looking forward to hopefully more of these in the future, because I think, as much as you deal with back pain, there's some other areas where you also see patients and really kind of get them into a better quality of life. And it's such a powerful thing that you're doing. We just can't tell you how much we appreciated the time today.
No, it's been a pleasure. Thanks, Forrest.
Thank you.